Thank you very much, Kat, and thank you all for attending today. My name is John Combs. I'm the Chief Medical Officer for the American Hospital Association, and thanks again for joining us today for the Clinical Pharmacist Chronic Pain Services, Implementing Interprofessional Care. This webinar is brought to you by the AHA's Physician Leadership Forum and the American Society of Health System Pharmacists. To present today's session, we are pleased to have with us Dr. Lori Tischler, Medical Director of the Phyllis Gen Center for Primary Care at the Brigham and Women's Hospital, Dr. Edgar Ross, Director of Pain Management Center at the Brigham and Women's Hospital, and Dr. Michelle Matthews, Associate Professor of Pharmacy Practice and Clinical Pharmacy Specialist in the Pain Management at the Massachusetts College of Pharmacy and the Health Sciences University, as well as the Brigham and Women's Hospital. With that, let me turn it over to Michelle to get us started. Michelle?
Good afternoon, everyone. Thank you so much to Dr. Combs and the American Hospital Association for the opportunity, and to the American Society of Health System Pharmacists for considering me and my team to highlight the services that we've developed for patients with chronic pain. It's an absolute honor to be able to share our experiences with developing services for a truly complex and challenging patient population. The purpose of this presentation will be to review types of pain management-specific clinical pharmacy services that can be integrated into various health system settings, describe how interprofessional collaboration can offer benefits to both staff and patients, and identify opportunities to enhance outcomes for patients with pain, including those with risk factors for substance abuse. Chronic pain is increasingly recognized as a disease, and the National Pain Strategy, which was released last week, which is considered a roadmap towards achieving a system of care in which all people receive appropriate, high-quality, and evidence-based care for pain, calls for several approaches, including developing methods and metrics to monitor and improve the prevention and management of pain, supporting the development of a system of patient-centered integrated pain management practices based on a biopsychosocial model of care that enables providers and patients to access the full spectrum of pain treatment options, taking steps to reduce barriers to pain care and improve the quality of pain care for vulnerable, stigmatized, and underserved populations, as well as increasing public awareness of pain, increasing patient knowledge of treatment options and risks, and helping to develop a better informed healthcare workforce with regard to pain management. And particularly important as this relates to medication use, the National Pain Strategy provides opportunities for reducing the need for and over-reliance on prescription opioid medications, including improving provider education, improving patient self-management strategies, encouraging the evaluation of risks and benefits of current pain treatment regimens, providing patients with educational tools to encourage safer use of prescription opioids, and conducting research to identify how best to provide the appropriate pain treatment to individualized patients. And I think it's important to also mention some of the other reports that came out last week, one including the CDC guidelines for prescribing opioids, which was designed specifically for primary care providers. And then also here within Massachusetts, there have been several regulatory changes that were passed last week, which will affect patient access to care, but also may assist with preventing the overprescribing of these medications. So this is a very challenging time in terms of how medications fit into chronic pain management, and I think this further highlights the importance of having a pharmacist involved as part of the care team for the management of patients with chronic pain. Before discussing patient-specific pain management services, I think it's important to review how the role of the pharmacist has advanced through the years. Beginning in the 1960s, this was the first time that pharmacists began using medical information to verify the appropriateness of prescriptions. Moving on to the next decades in the 70s, professional pharmacy organizations, including the American Society of Health System Pharmacists and experts from other professions, began developing standards for clinical pharmacy practice, and the first of its kind clinical pharmacy program is integrated into a family practice clinic in Iowa. In the 1980s, the Department of Veteran Affairs establishes clinical pharmacy services, which to this day have been a model for interprofessional team-based care particularly for its ambulatory care services. And in the 1990s, HCFA, which is now CMS, conducted a review of available outcome data for clinical pharmacy services and determined that such services added value to patient care. What also happened during this decade was the Asheville Project, which was launched in 1997 by the city of Asheville, North Carolina, and provided education and personal oversight for city employees with chronic health problems such as diabetes, asthma, hypertension, and high cholesterol. Employees with these conditions received intensive education through a local diabetes and health education center and were teamed with community pharmacists who made sure they were using their medications correctly. These pharmacists were trained in a diabetes certificate program and were reimbursed for pharmaceutical care services. There were significant improvements in patient outcomes and a reduction in employer medical costs. Additionally, postgraduate training programs for pharmacists started to increase during this time, and the standards for these programs were developed by ASHP along with other professional pharmacy organizations, and ASHP has maintained responsibility for accrediting these programs. There are now more than 1,000 postgraduate Year 1 pharmacy residency programs available, with an increasing number of specialty residencies as well as fellowships. And this brings us up to date. So there are several specialty certifications available for pharmacists through the Board of Pharmacy Services. And when these were first created, they were done so specifically for pharmacists working within acute care settings. In the 2000s, this was expanded to pharmacists that are working within ambulatory care, and several other certifications are now available as well. And the availability of advanced training and certification for pharmacists has allowed for widespread integration in various health system settings and has assisted with the establishment of reimbursement models. In 2009, I was invited to a summit sponsored by the May Day Fund and was asked to work with a group of other pharmacists. There was probably about 50 or 60 of us from across the country that are actively working within pain management-specific services to develop competencies for pharmacists who are or will be participating in pain management-related services. And we also further outline the deficiencies in pain management education within pharmacy school curricula, as well as within postgraduate training. And our recommendations are summarized in this slide. We felt that all of the items listed here are necessary for pharmacists who are going to be practicing in both acute and outpatient services as they relate to pain management. In addition, there are numerous services that pharmacists can be involved with to ensure effective pain management as well as the safe and appropriate use of analgesic therapy. And I was hoping to review some of this information so that I can tie in some of the things that I've already started to do within Brigham and Women's Hospital. Some of these things are very general and things that most pharmacists are able to do through the training that they get through the Doctor of Pharmacy program. And some of these other items are things that are related to the competencies that I mentioned on the slide prior to this. The first one is medication history review and reconciliation. I think from a pharmacist perspective, this tends to be one of the important acts that we can do with the patient in terms of patient assessment, not only getting a patient history and assessment of their adherence, but also calling the pharmacy, checking the prescription monitoring program. Once we have all that information, we can make recommendations for starting, changing, or stopping medication therapy. I mentioned already the importance of assessing adherence and also the integration of techniques such as motivational interviewing that can help with assisting patients with changing some of the behaviors that are leading them towards being non-adherent or not engaged in their health care. Pharmacokinetic and clinical monitoring of medications is done in almost all healthcare settings, including the inpatient side where antibiotic monitoring such as vancomycin becomes very important. On the outpatient side, specifically in pain management, there's a lot to think about in terms of the individualized approach to management, the genetic predisposition that some patients have in terms of opioid receptors, and how opioid analgesics will respond in individual patients. So there's multiple aspects of monitoring that pharmacists are capable and trained to evaluate in this particular population. Drug formulations and regimens are becoming increasingly more complex, And patient education becomes paramount, especially if there are medications that require self-administration, such as injectable medications. There's also an important approach to monitoring the therapeutic effects, drug interactions, adverse events that the patient may be at risk for. So there's this concept of potential or actual drug-related problems that we evaluate when we meet patients and monitor them over time. And then one of the things that I spend a lot of time doing in this population is the identification and monitoring for behaviors related to medication misuse, abuse, and or addiction. And some of the tools that we use are the opioid risk tool, the screener, and opioid assessment in pain patients, as well as urine toxicology screening, which I spend a lot of time interpreting, not only for the patients I work with, but also the providers that are asking questions about, does it make sense for the regimen that's prescribed for the patient? And I mentioned earlier as well the prescription monitoring program, which plays a very important role in terms of identifying inconsistent or inappropriate prescribing patterns. In terms of facilitating communication between care team members and pharmacies, one of the things I hear as a primary frustration for physicians tends to be the communication or lack thereof with many of the pharmacies. So that's one way that pharmacists that are working in the clinical environment can be helpful to bridge those communication gaps between the patient coming to the pharmacy with just a prescription versus the provider having access to all of the medical information that would be helpful, and ensuring that there is proper communication in terms of appropriateness of the prescription as well as the safe use. There's also an increase in evaluating patients for appropriateness of naloxone. There are criteria that are available and also criteria that I apply to the patients that I work with to determine who those patients are at risk for an opioid overdose, and selecting which patients are appropriate candidates to either receive a prescription from our clinic or to educate them on the availability of naloxone, which in many states is available without a prescription, or in some cases available through a scope of practice and a standing order, similar to the way immunizations are available within the pharmacy. There are opportunities for pharmacists to be involved with academic detailing and identifying trends in analgesic prescribing, as well as to work with different organizations and teams within the health system setting to develop quality improvement projects that can help to ensure proper patient care as it relates to pain management. So there are several practice models that can be considered for pharmacist involvement. Through my affiliation with Brigham and Women's Hospital, I have the opportunity to participate in patient care as a member of an interprofessional team at our pain management center, which includes physicians, nurses, psychologists, physical therapists, acupuncturists. Additionally, I serve as a provider extender, and the title that I'm afforded at the hospital is an advanced pharmacist practitioner, which provides me with privileging that is similar to nurse practitioners and physician's assistants. Additionally, because I'm fully salaried by MCPHS University, which is the pharmacy school that I work for, my students play an important role in the patient care services that I provide, and there are increasing models of successful student integration into pharmacy services. One of the terms that I have listed on this slide is collaborative drug therapy management. I'm going to spend some time discussing this. So before I define it, I do want to just share some of the regulatory changes that have happened over the past, I'd say, 10-plus years. There are state-specific regulatory changes that have paved way for the prescriptive authority for pharmacists through collaborative drug therapy management. Some states require extensive pharmacist training, including postgraduate training, practice-specific certifications, and additional annual continuing education credits. Specifically in Massachusetts, the statutes as they relate to the advanced role of the pharmacist include having the pharmacist hold a valid license, having appropriate medical malpractice coverage, having a degree with 5 years of experience. So these are not, pharmacists that are working in these environments are not coming right out of college into these positions. There's additional postgraduate training and years of experience that are expected. Pharmacists are required to do 5 additional continuing education credits in all practice areas, as well as maintaining state and federal controlled substances licenses. So I have my own controlled substance registration for the state as well as my own DEA number, and there also has to be sufficient and appropriate record keeping. So I mentioned this term CDTM, and I just want to define it for you. So this would be a collaborative approach to healthcare delivery where the pharmacist and prescriber, which would be the physician, establish written guidelines or protocols to authorize the pharmacist to function in certain ways. And in particular, within the pain management population would be specifically to initiate, modify, or continue drug therapy for a specific patient. So there's clear guidelines and specific parameters that the pharmacist must be kept within in terms of particular scope of practice. There's usually a CDTM agreement that is developed, and it's written and signed between the authorized pharmacist with training and experience relevant to the scope of the collaborative practice, as well as the supervising physician that defines the collaborative practice in which the authorized pharmacist and the supervising physician propose to engage. And this can also be done in a community pharmacist setting as well. From my perspective, I think there's multiple benefits to integrating CDTM into various health system settings. Two that I think are important to highlight are having us practice at the end of our license. So it allows us to take full advantage of all the knowledge that we get through our doctor of pharmacy program and to couple that with the training that we get within our specific practice areas. So whether that be postgraduate years 1 and 2 training, certifications, et cetera, to allow us to work at that top aspect of our license. And it also helps reduce delays in changes to drug regimens that might be necessary. Some of the visits to my particular clinic can help with bridging the communication between the patient, their primary care provider, and other specialists that the patient might be working with, and also helps us keep a close eye on adherence to the drug therapy plan. So to begin thinking about integrating these services into our institution, there's a couple things that had to happen. I'm going to have Dr. Ross and Dr. Tischler share their experiences with establishing the pharmacy-specific pain management services. But the way that we would identify and define a successful collaboration would be that what we're doing is easily defined for what it can do for the patient, that it's based on standards of care so that it can be delivered consistently from one practitioner to the next and from one patient to the next, that it integrates with the rest of the healthcare team via consistent terminology, philosophy, documentation, care process, and standards of practice, and that it generates measurable results that are reproducible. And although I'm not going to spend much time on this, that we're also looking for the business side of this too, is this service reimbursable? Some of the obstacles that are often encountered when trying to implement CDTM are difficulty obtaining acceptance from other care providers. And I have been doing this for about 15 years now, and I haven't always had the opportunity to work with thought leaders like Dr. Ross and Dr. Tischler, who've been immensely helpful in helping us to educate all members of the care team on the importance of having a pharmacist involved in more of a clinical environment. Sometimes there's lack of support from administration. Sometimes the process to get credentialed, similar to the credentialing that I have, is a very slow and painstaking process. Sometimes there's not enough pharmacists out there with the skill set that you think is necessary to integrate into the service. And sometimes there's not enough space. And I'd have to say from my perspective that I've been grateful to have the space that I have to perform the duties that I do within my clinical practice. But I also have a lot of trainees, a lot of residents and pharmacy students that are with me at all times. So sometimes space becomes a little bit of an issue as well. And as I mentioned earlier, the most important piece for me was identifying who those physician champions could be to help with allowing these conversations to move forward and be the visionary so that we can help establish these services for a population that very much needs them. So with that, I'm going to turn it over to Dr. Ross to share his experiences at the Pain Management Center.
Thank you, Michelle. So I must say that It's been an very, very easy integration of Michelle into our clinic, and it really didn't take a great deal of foresight to understand how she could contribute, and in fact, she's exceeded all of our expectations. There are many different areas where a clinical pharmacist can be of incredible help. So it's med reconciliation, the patient education, particularly when to take medications. Many of our patients are on multiple different medications with potential drug interactions. So timing, diets are always a concern that are raised by some of our patients, and the ones that we don't have ready access to teaching them how to stick to a regimen and making sure that they get the optimal effect. The recent regulatory changes, both on a national and statewide level, I think have only increased the need for pharmacists. I've gotten numerous calls from pharmacists in the community filling medications. They're concerned about their license. They're concerned about what happens if a particular patient, opiates are seemingly high. It doesn't necessarily mean even in the situations where patients have cancer, they still have these questions. So Michelle can go a long way towards reassuring the community pharmacists that the documentation is in place, that indeed all the vigilance that's required for appropriate and safe prescribing of opiates are in place and well documented. One of the major issues that I've always wrestled with over the years, where Michelle has been extremely helpful, is in our outreach program. So connecting the pain center where the specialists see patients and where we work to a primary care facility such as what Lori Tischler runs Michelle has been incredibly helpful. Not only can she do the referrals, she can pick up the patients which may be problematic and may have compliance problems or require further pain management approaches that are more specialized, such as what's found in the pain center. So the way we went about approaching and asking Michelle to come on board is what's our needs assessment. And I've just described some of those needs assessments that we went through. But also even the whole concept of a mid-level practitioner, and that even though we have nurse practitioners and we have access to physician assistants, the pharmacist brings a unique background that has been very, very helpful, as I described earlier. We had to have discussions with Brigham Pharmacy and discussions with the pharmacy school. Clearly this was to some degree novel, but the people I worked with thought that this was a wonderful model program based on some of the experiences that have other clinical services such as oncology, which have had well-established embedded pharmacists in the past. We just changed the model to suit our own needs, and it has been everything that we expected and more. And I think this team approach in this era of complicated regulations, rapidly moving public health concerns, a pharmacist brings a unique spectrum of skills that I don't know how we would be able to run a service without them at this point. And with that, I can hand it back.
Thank you very much, Dr. Ross. Dr. Tischler?
Thank you, both Michelle and Ed. I echo so much of what Ed has said. When I think about our practice, we are a large academic teaching practice. So we have a number of part-time faculty who see patients in our practice and about 65 residents who see patients in our practice. We are urban-based, and I think of us as having two vulnerable populations, our patients first, of course, and our residents. And it is very challenging to manage opiates in patients in this setting, and has always been a significant challenge for us. So we have always been looking for ways to do it better. We had been working with an embedded pharmacist prior to Michelle, whose primary interest was in chronic care management, and that was a fantastic experience and has continued to be a fantastic experience. And we had gotten to a point where the opioid prescribing was very challenging, and I reached out to Ed to think together about how we could do this better. We didn't necessarily feel that our patients always needed to go to the pain clinic, and the patients didn't like to go there, but we did feel that both our learners and our providers really needed help. And I think this was about the time that Michelle had started, and Michelle had a significant interest in primary care, and we worked together. So this was a fantastic experience in terms of sharing across departments in the hospital, and then also across interprofessional teams. One huge role that I envisioned Michelle playing at the beginning, and she continues to do this, was to help us know which of our patients really needed to go to the anesthesia pain service, who really needed the very specialized services that Ed and his team can provide. And then also to help the patient get from our practice, where they're comfortable, to Ed's practice, which is actually in another part of the community, and to get there. So I think that was a huge thing. We also are moving toward becoming a patient-centered medical home, and we work on teams, and having a pharmacist as part of the team was a natural fit that made sense for us. And I would say that it was very smooth in terms of Michelle is easy to work with. She knows her stuff, and she works very well sort of across the continuum. For us, one of our bigger challenges was getting everybody to know that Michelle was in the practice and how she could help the patients, what she could do and what she couldn't do. And from the very beginning, Michelle was wonderful with things like medication reconciliation and education, but she also educated us on rotating opioids, ensuring proper use of analgesics, and also volunteering to actively help us for patients who may not have been on the most appropriate regimens with what Michelle calls an exit strategy. And it's been a wonderful collaboration. So, Michelle, I will hand it back to you.
Thank you very much, Dr. Tischler and Dr. Ross. And I appreciate all the compliments. I kind of wish my parents were on this webinar right now, so thank you very much.
I was going to ask you, too bad we don't have video conferencing and watch you blush.
And it would be so well-deserved.
But I do want to mention that although I know that you continue to mention my name, and I do appreciate that I do think that someone else with the same skill set would be able to kind of come in and replicate what I'm doing and have it be a very seamless transition. And I think that's what all of us hope for who help establish these programs, that this can be replicated. It doesn't, I mean, I think that pharmacists that are going to be working in this environment with this patient population want to be doing it, are passionate about it. So I'm confident that that other pharmacists can do this as well. But thank you very much.
And I definitely concur. We have worked in the Gen Center with probably 4 or 5 different clinical pharmacists on various different projects, and it's always been a really positive collaboration for us.
Thank you very much. So now what I'd like to do is highlight the role that I play within Brigham and Women's Hospital. You heard from 2 of the thought leaders and visionaries that I've had the ability to work with, and this is what it has led to. So there are 2 roles that I play. One is within team-based care within the Pain Management Center, and then the other is as a pharmacist clinician within the primary care clinic, where I direct the majority of the pain management for the patients that are sent to my clinic. And as Dr. Ross and Dr. Tischler mentioned, there are some times where I'm serving in a triage role to make a determination about which of those patients need to be referred further to more comprehensive pain management services, such as what's provided through our Pain Management Center. There were multiple steps involved with getting this collaboration up and running, and I just want to highlight some of those. So I mentioned the CDTM agreement. That was one pivotal piece to help structure and outline the responsibilities that the pharmacist will have. And that needed to be approved by basically all of the important people in the hospital. The Office of General Counsel, the Medication Executive Committee, as well as the Pharmacy and Therapeutics Committee, which I continue to meet with on a biannual basis to check in and kind of update them on the progress and also sharing some of the patient outcomes. The clinical protocols require that the supervising physician has to work within the same scope of practice, that they have to be reviewed and renewed on a biannual basis, and then also making sure that the documentation for the referral process as well as patient consent is very clear. So through this process, this led to credentialing and privileging as an advanced pharmacist practitioner, and this allows me to have prescriptive authority under collaborative drug therapy management protocols for 3 specific patient populations: chronic low back pain, neuropathic pain, and fibromyalgia. What I am not allowed to do is provide general anesthesia. I think that's obviously a given. Perform procedures relating to radiation. I cannot be the sole medical personnel in charge of emergency services, outpatient services, or any other clinical service where licensed physicians are not available. And I may not diagnose a new condition for a patient. And that is why making sure that the diagnosis is clear before referring the patient to the service becomes really important. This slide highlights for you all the reasons for referral. The criteria on the left tends to be general and to what we do as pharmacists, and what I've listed for you in the right column is basically some of the more common reasons that patients are referred specifically for pain management services with the patients that I work with. So polypharmacy, especially patients on a combination of high-risk medications like opioids and benzodiazepines, patients that are on high doses of opioids, those that are determined or it may not be clear if these patients are high risk for opioid misuse. Dr. Tischler mentioned something I call exit strategy. So who are those patients where maybe opioids are no longer indicated or patients developed an opioid use disorder? How do we deal with not only addressing taking the patient off that medication, but addressing the pain management needs that will surface once that medication is no longer part of the regimen? And then lastly, coordination of care, which would require obviously very good communication skills. So the referral process, all of my referrals come from the primary care provider within the Gen Center or from one of the pain physicians that works in the pain management center. And at that time, the physician will communicate the official diagnosis and any goals of therapy that they think are important. Obviously, as the pharmacist, I would be involved with defining some of those goals of therapy as they relate to the safe and effective use of medication. So I'll evaluate the need for drug therapy or appropriateness of the current therapy, and then at that point, we'll deem if it's appropriate to start, change, or discontinue drug therapy. And the evaluation that's involved here will look at past medications and adverse drug reactions to medications that they've used prior to referral or medications they're taking right now, any allergies or intolerances to medications, if there's medications that a patient's on that seems to just be duplication of therapy, such as being on multiple muscle relaxants, identifying any interactions as they relate to drugs interacting with themselves, the disease state, the diet the patient has, supplements, and any lab work, because there is some screening that we do in terms of urine toxicology that may be disrupted by certain medications the patient takes, as well as non-adherence to medication therapy. In terms of developing the treatment approach for these patients, what I've identified are some of the validated tools to assess both pain and function in these 3 specific populations. So I use the brief pain inventory to evaluate improvement in pain for patients with chronic low back pain and fibromyalgia, and also use the pain disability index to identify improvement in function for that same population, and then also the fibromyalgia impact questionnaire for those with fibromyalgia. And I do keep track of these outcomes, and as I mentioned previously, I am required to report these outcomes to the Pharmacy and Therapeutics Committee on a very regular basis, again, to make sure that what we're doing is not causing harm to the patient, but is actually associated with improving those outcomes. In terms of the selection for specific medications that might be started, there are algorithms that I have developed for these 3 specific areas of pain management, and I also have been authorized to utilize our hospital-approved pain management tables and guidelines, which I'm happy to share. My email address will be at the end, so that you can see some of the medications that are commonly prescribed for this population that is referred to me, and helps with some of that decision-making. So it's not any medication. I can't, if a patient comes in and asks for a refill on their statin, I cannot prescribe that. I can refer the refill to the appropriate prescriber, but I have to stick within my scope of practice. In terms of monitoring and follow-up, I see patients on a very regular basis, sometimes monthly, sometimes every 2 weeks, and that decision is often made by risk factors that the patient has. One, for possible adverse events related to the regimen that we're initiating or modifying, or 2, because of some risk factors that have been identified in terms of medication misuse. And one of the things that I've struggled with is I continue to work with these patients, and Dr. Tischler can agree with this, and I've been working with some of these patients on a regular basis for years. So the plan, I think, in many of the situations is to get the patient stabilized and transition the care back over to other members of the care team, including the primary care provider. And interestingly, the report from patients, when I tell them that I think it's time for them, to be seen less often, many of them don't want to, because I think what it allows them to do is, with the time that I give them during my visits, is really I have time to listen to them. I have time to kind of really get a good sense of how their pain is, how their medications are being used. And I think that with all of the competing demands that we now have in healthcare, that sometimes patients are not always given or have the opportunity to share that amount of time with a clinician. So I think that helps with elevating the patient satisfaction level. Additional aspects of drug therapy monitoring that will be involved include assessing pain relief, adverse effects, evaluating function through validated tools, identifying any behaviors that might be concerning for misuse, abuse, and addiction, identifying if there's been any sort of change in the patient's affect or mood, because those things can unfortunately, one, affect risk factor or have an effect on use potential of these medications, but may also be worsened by some of the medications that we use for pain management. Making sure that there are other drug therapies that are considered, especially if it's a patient on opioids, and then ensuring that the patient is adherent, is able to access their treatment, and that they've been able to afford it as well. This is a sample protocol that I'm sharing that is included in my collaborative drug therapy management agreement for patients with chronic low back pain. I am more than happy to share my protocol with any of you that are interested. But what you can see here is this walks through, once the diagnosis of chronic low back pain is clear and that the pharmacist has received the appropriate referral from the physician, at that point there's an evaluation of the current analgesic regimen. There is consideration of modification of that regimen, discontinuing medications that may be inappropriate, and then going into a more comprehensive evaluation on whether or not opioid therapy can be indicated. A discussion on the evidence of opioids for chronic low back pain can be had on another webinar, but I do think it's important to consider that some patients, even though the evidence is not strong, may be appropriate candidates under the right circumstances. In terms of the successes that I've experienced related to patient outcomes, the most recent kind of crunching of the numbers that I've done identified that there's been between a 30% and 40% improvement in pain for patients with chronic low back pain and neuropathic pain after they've been referred to my service. These numbers that I'm sharing with you are really difficult for, one, me to collect, and two, I think, to interpret, because pain is such a subjective experience, and I don't know that changes in pain score is the best outcome measure for this population. What I have heard from patients is that many times they're more satisfied with understanding their pain, understanding why certain medications are being recommended to them, and then also the communication piece. And I'll just use an example from a patient that I met with this morning who I've been working with for many years, was a history of chronic abdominal pain in the setting of chronic pancreatitis, where prior to him being referred to my clinic, he had an average of 14 hospital visits for acute flares of his pain, and we've been able to reduce that to 1 to 3 visits per year. And that, to me, is a pretty significant outcome, because we can actually tie a lot of cost to that. So these patients end up utilizing high-cost health services less. They visit the emergency room or urgent care for pain complaints a lot less often. And I'm now going to turn it over to Dr. Ross to discuss his mini SWOT analysis about how we've been doing with integration of pharmacy services.
Well, I think the strengths have overwhelmed any other areas that needed for improvement. So by far and away, this has been an extremely positive experience for both myself, my service, and all the physicians and nurses who are practicing in the pain center. I think probably the most significant area where we need to improve is obviously getting the CDC guidelines that just came out, and how to teach that to the primary care doctors. On one hand, we have a great deal of fear and from sanctions that are now becoming much more visible at the primary care level, starting people on opiates. So I worry about, particularly when it comes to cancer patients, I worry about that. There's the pendulum is going to swing the other way. And also the 7-day refill requirement now from our state is also somewhere where I think patients could fall through the cracks. So I think, as Michelle mentioned, the emphasis on function, not pain scores, is extremely important. And reaching out from our center, where Michelle interacts with at the primary care level, providing that guidance is going to become vital in the future. The other part of this is the 50 milliequivalents to morphine that the CDC guidelines now suggest for all new starts of patients in pain. Even calculating that with all the varying opiates is going to need specialized expertise. So I think I see this as both areas for improvement, but also the opportunities that can arise from a collaboration. How a pain center can basically guide patient care, not just on an outpatient setting, which has been the traditional focus for us, but on the inpatient setting and the surgical, post-op surgical management and the ER management, where issues of opiates come up repeatedly over and over and over again. And I see that as our initiatives that we need to crystallize in the near future. Thanks, Michelle.
Thank you. And now I'm going to turn it over to Dr. Tischler.
I think we've talked a lot about what the strengths have been with having what we call in the John Center a pain pharmacist. I think that our areas for improvement have to do a little bit with what Michelle was saying, is helping develop sort of an entrance and an exit strategy for the pharmacist service. Which of the patients? Because I think in many ways, especially in our resident panels, they would like every patient to see Michelle. But which are the patients that are the best candidates for the work that Michelle does? When is that work completed and can be turned over to another provider most appropriately? We always have challenges, as she said, with space and booking and things like that. We are also working on improving our processes for prescribing opiates for all of our patients, not only to be in compliance with the new federal regulations and state laws, but to really be doing a better job by our patients. And I know that Michelle is playing a large role in our development of these processes. Another thing which we hadn't mentioned, and is probably a little bit out of the scope of this conversation, is that Michelle has also been involved in a project that we have been working on for patients who have opioid use disorder. and we have a small number of patients who are getting buprenorphine. And Michelle has been instrumental in helping us understand which patients are the best patients for that and helping to initiate treatment and follow up with treatment. So I think that's another place that that we can grow and that Michelle can help us grow.
Thank you very much. Okay. So that walks you through how the clinical services were established, what the criteria is that was important to allow everybody to, one, be educated on the scope of practice that the pharmacist will have in terms of working with this patient population. But what I have not talked about yet is, because this technically can be established like a business model, is what are the opportunities for reimbursement. So there are some defined facility codes and CPT codes, incident to billing that can be done. And the payment models for pharmacy services in general has been in existence for more than 30 years, but has certainly evolved, especially now that there's more opportunities through the Affordable Care Act, as well as a federal legislative push for pharmacist provider status. However, the current reimbursement models are very clear for specific disease states, such as diabetes, immunizations, medical annual wellness visits, but when it comes to pain management, it's a little bit less clear. So I think if any of these, if reimbursement is an important component to establishing a clinical pharmacy service, this does need to be developed like any other business model, where there needs to be a needs assessment, SWOT analysis, gap and feasibility analyses, identifying what the true financial opportunities are, both within Medicare, Medicaid, as well as some of the private insurers, and then making sure that those outcomes are measurable and appropriate. So I am not currently billing for my services. I live in a little bit of a utopian world in terms of me being an academic clinic, but I do foresee at some point that we will be venturing down this road once we have provider status on a federal level. The future directions that I see myself going in, and as well as other pharmacists that are actively practicing within pain management, are more integration of technology, more utilization of some of the testing that's now available to help us further personalize individual management plans for patients that take into account variances in metabolism and opioid receptor subtypes. As well as transitional care management. So I get a lot of referrals related to patients that were recently hospitalized for acute pain, who are being discharged on really high doses of analgesic regimens, patients that are maintained on opioid regimens and are going into the hospital, either who will develop anticipated acute pain or those that develop acute pain flares or have trauma. Those patients become really challenging. And I know that Dr. Ross has talked about developing a transitional care program for patients that are being treated for acute pain who are opioid dependent in the hospital setting, and I fully see a pharmacist being an important member of that team as well. So there's a lot more that we can be doing and taking advantage of some of the new technology, such as mobile applications. I know that Dr. Ross has been working on developing a pain app, which we've started to use in our patients within the Pain Management Center. So there's a lot more to come and a lot more that we can do to integrate these services effectively. So recommendations for increasing patient access to pharmacist clinical services will be to work with and be an advocate for some of these regulatory changes that have allowed us to practice under collaborative drug therapy management. Do what we can to support efforts to ensure that the infrastructure is there, not only for pharmacist education, but also the advancement after graduation through postgraduate training and certification programs. And then again, the technology, we recently transitioned to a new medical record system, and I think it has a lot of capabilities to allow pharmacists to be able to ensure that that referral process is happening, that we have the right information that we need to evaluate the patient's analgesic regimen, and then also to make sure that we can communicate effectively not only with the patient, but with the care team as well as the pharmacy that the patients are using. So in summary, there is a significantly changing landscape for chronic pain that warrants an interprofessional approach. And this can be done successfully, as evidenced from the discussion that we're having today, where There has been improvement in patient outcomes. Dr. Ross and Dr. Tischler shared their positive experience with this program. And as I mentioned, there are some opportunities for financial incentives by having such services available as well. So with that, I leave you with some resources specific to some of the professional pharmacy organizations that have been integral with advocating for pharmacist advancement of these clinical services and their websites. And our email addresses should you have any questions about any of the material we covered today. And thank you again to the AHA, Dr. Combs, and ASHP for having us.
Thank you very much, Dr. Ross, Tischler, and Matthews for that outstanding presentation. I'd like to turn it over to the operator now to open up the line and give instructions for people to ask live questions.
Thank you. The floor is now open for questions. If you do have a question, you may press *1 on your telephone keypad at this time. Questions will be taken in the order that they are received. If at any time your question has been answered, you can remove yourself from the queue by pressing 1. If you're using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality. Again, ladies and gentlemen, if you do have a question or comment, you could type it in the chat box on your web screen or press *1 on your telephone keypad at this time. Please hold while we poll for questions.
Well, Kat, while we're waiting for some questions, let me get to some that are in the chat box. With all this interest from the regulators of the federal and state governments in opioid abuse, do you want to talk about the important differences in treating the chronic pain patient like you have and those who really need intensive pain management for palliative and end-of-life care?
I can take that question. Both groups have the needs for obviously optimization of pain, of their pain regimen. Clearly, for non-cancer pain, people who are on long-term opiates, the literature is rapidly proving or showing that more is not better. And that the multidisciplinary approach, using both function, the psychological state of the patient, and as well as opiates, but perhaps emphasizing even more non-opiate analgesics that are been shown to be helpful in a particular patient's pain condition, is vital in order for success in avoiding all the public health risks of high-dose opiates. But even in the palliative care, just throwing opiates at patients who are end of life won't be particularly helpful either necessarily. We want palliative care patients have other needs and goals, and particularly the interaction with their family. And large doses of opiates inhibit that as well. So it's basically the nuances of differences, but palliative care does not necessarily mean that you can just prescribe unlimited doses of opiates. It takes a judicious approach as well.
Thank you.
Yeah, and I absolutely agree with that. So there's increasing attention towards deep prescribing in the setting of palliative care and advanced illness. So, and I think even in the population I work with, which is primarily chronic non-cancer pain, I spend a lot of time taking medications away and educating, and that creates a lot of fear and concern on the patient's behalf because the medication was so centric to their pain management prior to meeting with me that it takes a lot of time for the patients to kind of move away from that mindset. And I had a patient this morning where she's got chronic non-cancer pain. She's been on oxycodone for years, and we recently talked about, the kind of running down towards the end of the line of where I think prescription medications could be helpful, and we referred her to an alternative medicine specialist. She's getting extreme benefits from things like acupuncture and peppermint oil, which are not things that I traditionally, acupuncture maybe, but not necessarily peppermint oil for some of these patients, and it's something that's been so helpful to her, and it's completely outside of the box of traditional medicine. So I think Dr. Ross raised some really good points that we're starting to really think more about when these drugs make sense, especially in the context of opioids.
Great. Operator, do we have any that came in on the live line yet?
No, we do not have any phone questions. Again, it's *1 if you do have a question.
Okay. I have a question, and I'm going to use the moderator's prerogative here. Given the overlay of behavioral health issues with patients who have chronic pain, how do you bring behavioral health into the team in your service, pain service?
Well, I'm blessed of having 2 psychologists and a psychiatrist whose subspecialty is addiction medicine as well. So it's very common to see a lot of comorbidities, either pre-existing prior to an injury or because of the injury. And so even though you may not have someone directly attached to the team, we all do CBT with patients, and we all need to be able to discuss with patients some of their life stressors and how that's impacting their pain experience. And having a community-based psychologist that has interest in treating patients with chronic pain can be invaluable outside of the large medical centers.
We also have an embedded psychiatrist in our practice and social workers who do short-term psychotherapy and medical social work. And they are, again, I think this is what we've all been saying, is that this is definitely requires teamwork, and these are integral members of the team as well.
Right. There's a question about who provides the clinical evaluation and follow-up of a patient's care after they've been in the clinic. Do they go right back to the primary care, or they go into your patient-centered primary care home?
They go right back to their primary care doctor. And because we have residents, we also have a lot of turnover. About a third of our residents turn over every year. And so our pharmacist also provides important continuity during that transition.
Great. And then the final question, I think we're out of time after that, is a question about whether or not you utilize urinary drug screens in your practice.
Yes.
Absolutely. It's absolutely vital.
Great.
The decision is usually made based on risk factors. That's universal precautions approach. In the beginning, everybody gets a baseline urine toxicology screen, and then the frequency thereafter is based on if the patient falls into the high risk category, those get done more frequently.
Right. And I noticed you answered on the chat box the questions about contracts and that you actually use them in your practice as well.
That's again a state law in Massachusetts, so
right.
The argument is over.
Right.
Those are useful or not.
Great. Well, I want to thank Dr. Matthews, Dr. Ross, and Dr. Tischler for an outstanding presentation that also came in on the chat box. Congratulations on your brilliant presentation and service to your patients. So thank you again. And I want to remind everyone that you can find a recording of this session with the slides at our website, www.ahaphysicianforum.org. Thanks again for all you participating on today's webinar, and please watch our newsletter and website for details on our next webinar on the findings of the Accreditation Council of Graduate Medical Education's Clinical Learning Environment Review with Dr. Kevin Weiss, scheduled for April 27th. Thank you all for your participation, and with that, Kat, I will turn it back over to you.